Good afternoon and welcome to the Washington Medical Commission webinar series. Today we are looking at transforming primary care for lesbian, gay, bisexual, and transgender people, a collaborative quality improvement initiative. Today we are honored to have CDC medical epidemiologist Dr. Furness with us. Before I turn the webinar over, I would like to take care of a few housekeeping items. We encourage you to ask questions throughout the presentation, so look for the question box on your webinar portal, and we will do our best to address your questions toward the end of the presentation. We hope that you do not have any technical difficulties, but if you do, look for the help button on the webinar portal to get your issues worked out. We are recording this webinar. The on-demand version and the slide deck will be available on our website within the next few days. Please feel free to share these resources with your colleagues. We want our learning events to be as interactive as possible, so please feel free to use our social media platforms to share what you have learned and keep the conversation going. This webinar is accredited for 1 hour of Category 1 CME by the Federation of State Medical Boards. If you are watching this in a group setting, please make sure you register for the webinar and complete the evaluation as an individual to receive CME credit. A link to the post-webinar evaluation will be emailed to you after the presentation. Please complete this evaluation within the next 2 weeks to receive CME credit. The evaluation link will also be available on the webinar webpage. This webinar is not funded by any commercial entity, and the speaker, course director, and planners at the Federation of State Medical Boards and Washington Medical Commission have nothing to disclose. Now, with all of that out of the way, I will turn it over to Dr. Furness.
Before I get started, I wanted to mention that the currently accepted acronym for sexual and gender minorities is LGBTQIA, with the I and the A being intersex and allies, or if you want to shorten that, LGBTQ+. But this presentation primarily focuses on lesbians, gays, bisexuals, and transgender persons. I also want to point out that gay and bisexual are identities, and much of the data that I'll be presenting today is on men who have sex with men, or MSM, which is based on behavior. So who am I? Why am I here talking about this topic? I am, as Jimmy said, a medical epidemiologist within the Division of STD Prevention at the Centers for Disease Control and Prevention, and I'm considered a subject matter expert on LGBT healthcare. I've been embedded within the Washington, D.C. Department of Health since 2002, and I've worn many hats during that time. Notably, for this presentation, I started and ran the Transgender Health Clinic at Whitman Walker Health from 2004 to 2009. I have been a volunteer physician for Whitman Walker Health's Tuesday and Thursday evening gay men's health and wellness clinics since 2003. And I've run the DC Health and Wellness Center PrEP Clinic, which predominantly serves men who have sex with men and transgender females of color. In addition, I'm a member of the National Coalition of STD Directors. I'm on their MSM Advisory Committee, and we work on things like extragenital STD screening call to actions to the STD program directors around the country. I'm also part of the National Coalition for Sexual Health on their Healthcare Action Group, and we work on things like sexual health questions to ask all patients, which I'm actually going to be talking about later in this presentation. So by the end of this presentation, you should be able to describe 3 disparities in access to care and health outcomes that LGBT patients experience, identify data which can be collected, monitored, and evaluated to enhance culturally affirming care for LGBT patients, and summarize 3 initiatives that have been shown to enhance culturally affirming care for LGBT patients. Next slide, please. Much of what I'm presenting today comes from 2 recently published journal articles. Transforming Primary Care for Lesbian, Gay, Bisexual, and Transgender People, a Collaborative Quality Improvement Initiative, came out in the Annals of Family Medicine this past summer. And then Using Sexual Orientation and Gender Identity Data and Electronic Health Records to Assess for Disparities in Preventive Health Screening Services came out in the International Journal of Medical Informatics in October. Next slide, please. Before we get started, I want to review why this topic is so important. Research suggests that LGBT individuals face health disparities linked to societal stigma, discrimination, and denial of their civil and human rights. Discrimination against LGBT persons has been associated with high rates of psychiatric disorders, substance abuse, and suicide. Experiences of violence and victimization are frequent for LGBT individuals and have long-lasting effects on the individual and the community. Specifically, LGBT youth are 2 to 3 times more likely to attempt suicide and are more likely to be homeless. Lesbians are less likely to get preventive services for cancer, and with bisexual females are more likely to be overweight or obese. Gay men are at higher risk for HIV and other STIs. Transgender individuals have a high prevalence of HIV, STIs, victimization, mental health issues, and suicide. In addition, they are also less likely to have health insurance than heterosexual or LGB individuals. Elderly LGBT individuals face additional barriers because of isolation and a lack of social services and culturally competent providers. LGBT populations have the highest rates of tobacco, alcohol, and other substance abuse or use. Next slide, please. Sorry. I want to start by taking a closer look at data on sexually transmitted infections among MSM. Okay. Sorry, Jimmy. Next slide, please. This is a map, a US map, showing estimated rates of reported primary and secondary syphilis cases among men who have sex with men by state. In 2018, 44 states provided data to classify at least 70% of their cases as MSM, men who have sex with women only, or women. Among these areas, estimated rates of primary and secondary syphilis cases in MSM range from 108.9 cases per 100,000 MSM in Vermont to 962.3 cases per 100,000 MSM in Mississippi, with 28 states, or 64%, estimated to have rates between 200 and 500 cases per 100,000 MSM. And you can see that Washington State had 375 cases per 100,000 MSM. Next slide, please. This line graph shows percentage of urethral Neisseria gonorrhea isolates obtained from men who have sex with men attending STD clinics during 1989 to 2018. Overall, the proportion of Neisseria gonorrhea isolates collected in selected STD clinics participating in the gonococcal isolate surveillance project that were from MSM increased steadily from 3.9% in 1989 to a high of 38.5% in 2017. In 2018, this proportion was 37.2%. Next slide, please. This bar graph shows the proportion of men who have sex with men STD clinic patients tested and testing positive for urogenital gonorrhea and chlamydia by jurisdiction. In 2018, 31,650 unique MSM presented for care in 18 STD clinics in 9 jurisdictions. In total, 26,159 unique men who had sex with men were tested for urogenital gonorrhea and/or chlamydia. When examining positivity among MSM tested for each disease, urogenital gonorrhea positivity was higher than urogenital chlamydia positivity in 7 of the 9 jurisdictions, those being Baltimore, Miami, Multnomah County, New York City, Philadelphia, San Francisco, and Seattle. Urogenital chlamydia positivity was equal or higher than urogenital gonorrhea positivity in Massachusetts and Minnesota. The median urogenital positivity for gonorrhea among men who have sex with men was 7.9%, with a range of 4.3% to 13.3%, and for chlamydia it was 5.8%, with a range of 4.3% to 11.1% across the 9 jurisdictions. Next slide, please. This bar graph shows the proportion of men who have sex with men STD clinic patients tested and testing positive for rectal gonorrhea and chlamydia by jurisdiction. In 2018, there were 20,838 unique men who had sex with men tested for rectal gonorrhea and/or chlamydia. When compared to urogenital testing, rectal testing occurs less frequently in a majority of the jurisdictions. The median positivity for rectal gonorrhea, though, among men who have sex with men was 14.8%, so much higher, with a range of 7.6% to 18.1%. And for rectal chlamydia, it was 16.1%, also much higher, with a range of 10.2% to 20.8% among these jurisdictions. Next slide, please. This bar graph shows the proportion of MSM STD clinic patients tested and testing positive for pharyngeal gonorrhea and chlamydia by jurisdiction. In 2018, 23,739 MSM were tested at the pharyngeal site for gonorrhea and/or chlamydia in 8 of the 10 jurisdictions where data was available. Pharyngeal testing varied between 52.2% and 86.5% for gonorrhea and between 68.2 and 76.6% for chlamydia. Among men who had sex with men who were tested at the pharyngeal site for gonorrhea, the median positivity was 12.9%, so higher than urogenital but lower than rectal, with a range of 8.0 and 19.8%. In contrast, among men who had sex with men tested at the pharyngeal site for chlamydia, the mean positivity was 2.7%, with a range of 2.0 to 3.1%. Next slide, please. I'm now going to review the Collaborative Quality Improvement Initiative of the Transforming Primary Care for LGBT People project. Next slide, please. We developed a quality improvement initiative to enhance the capacity of 10 federally qualified health centers, or FQHCs, to provide culturally affirming care for LGBT people. The one-year intervention blended the models of practice improvement collaboratives and Project ECHO to facilitate learning and translate knowledge into action. And I will talk about Project ECHO again. FQHCs receive coaching in creating LGBT inclusive environments, collecting sexual orientation and gender identity data, which I'll talk about a little bit more, and taking risk-based sexual histories and screening LGBT people for syphilis, chlamydia, gonorrhea, and HIV. We used a pre-intervention, post-intervention evaluation design. Next slide, please. This map shows the geographic distribution of the 10 participating federally qualified health centers from Connecticut to California, with 3 sites chosen in southern states, Texas, Louisiana, and North Carolina. Next slide, please. Unfortunately, we didn't have any medical sites in Washington state specifically, or the Pacific Northwest in general, but we did have one as far west as Chapter, which was in the valleys of Los Angeles. Next slide, please. For those of you not familiar with Project ECHO, the acronym stands for Extension for Community Health Outcomes. Our endeavor was entitled Project ECHO LGBT. ECHO is a model connecting specialists to primary care providers through regular video conferences. These video conferences facilitate case-based learning, dissemination of best practices, and evaluation of processes and outcomes. Project ECHO has been shown to improve chronic pain management and hepatitis C diagnosis and treatment in community health centers. Basically, ECHO provides subject matter expertise to community health centers via telehealth to improve patient care. Next slide, please. In March 2016, federally qualified health centers were required by the Health Resources and Services Administration, or HRSA, to start collecting and reporting annual aggregated sexual orientation and gender identity data on all patients that were adults, greater than 18 years of age. HRSA recommended collecting the sexual orientation data with this question: do you think of yourself as lesbian, gay, or homosexual, straight or heterosexual, bisexual, something else, don't know, or choose not to disclose? HRSA also recommends figuring out gender identity by asking these 2 questions. What is your gender identity? Male, female, transgender male, transgender female, other, such as genderqueer, or choose not to disclose. In addition, they also recommend asking what sex were you assigned at birth, with the 2 responses of male or female. Next slide, please. We focused on STI screening of men who have sex with men because there were national recommendations that were established. The following screening test should be performed at least annually for sexually active MSM, including those with HIV infection. So there should be at least annually an HIV serology if the HIV status of the patient is unknown or negative. There should be syphilis serologies, both a treponemal and a non-treponemal assay. There should be a test for urethral, chlamydia, and gonorrhea infections, especially in men who have had insertive intercourse in the preceding year. There should be a test for rectal chlamydia and gonorrhea infections in men who have had receptive anal intercourse in the preceding year. And there should be a test for pharyngeal gonorrhea infection in men who have had receptive oral intercourse in the preceding year. And these recommendations are for annual testing or more frequent testing depending on risk factors, regardless of condom usage. Next slide, please. We asked all 10 federally qualified health centers to capture and report the following measures monthly. Number 1 was the number and percent of all patients 18 years and older from the participating provider panels seen in the past year who had sexual orientation and gender identity documented in the electronic health record. The second measure was the number and percent of all LGBT patients seen in the past year who received a comprehensive sexual history with risk assessment. The third was the number and percent of all LGBT patients seen in the past year who were tested for syphilis, the number and percent of all LGBT patients seen in the past year who were tested for chlamydia and gonorrhea, and finally, the number and percent of all LGBT patients with negative or unknown HIV status seen in the past year who were tested or screened for HIV. Next slide, please. By the end of the intervention, all 10 health centers were routinely collecting sexual orientation and gender identity information based on the Health Resources and Services Administration guidance. But unfortunately, only 9 of 10 health centers were able to report to the SOGI monthly. This collection and reporting was the greatest success of this particular intervention. The number of clients with documented SOGI increased from 23,835 in March of 2016 to 104,583 in March of 2017. The percentage of clients increased from 13% in March of 2016 to 51% in March of 2017. Challenges overcome at the 9 health centers that were included with this data included choosing the best place in the electronic health record to collect sexual orientation and gender identity data. Some collected it during registration, some had the clinicians do it during their visit. Sites serving predominantly Spanish-speaking patients had to translate their screening tools multiple times, and at least one health center ended up using slang terms in order to get their Spanish-speaking patients to answer the questions as intended. Excuse me, health centers had to link the sexual orientation and gender identity data to other structured fields, such as ordered test or lab results, in order to use it to monitor and assess what they were doing. Next slide, please. It was a challenge getting health centers to adopt their electronic health records in order to collect and monitor risk-based sexual histories. At the end of the intervention, only two of the 10 participating health centers were able to collect and report sexual histories using their electronic health records. 4 more were able to report on sexual history taking based on manual chart review. Location of sexual histories within electronic health records varied from registration to progress notes to social history, and the top 2 barriers experienced among the health centers, the top 3, were providers not asking the questions, which we'll review in a minute, it's not uncommon, the data not being entered in the electronic health record, either appropriately or in the right place, and the third and final issue was issues extracting the data from the electronic health record. Next slide, please. By the end of the intervention, 8 health centers were routinely screening LGBT patients for syphilis. The number of LGBT patients screened for syphilis increased from 1,387 in March of 2016 to 2,587 in March of 2017. Surprisingly, the percentage decreased from 41% in March of 2016 to 35% in March of 2017. You're going to see this as a theme for the STD and HIV screening, and some of it is because the centers were doing a much better job at identifying through the SOGI collection and reporting who were sexual minorities and gender minorities. Next slide, please. By the end of the intervention, 8 health centers were routinely screening lesbian, gay, bisexual, and transgender patients for chlamydia and gonorrhea. The number of LGBT patients screened for chlamydia and gonorrhea increased from 1,577 in March of 2016 to 3,296 in March of 2017. But again, the percentage decreased from 46% in March 2016 to 44% in March of 2017. And I want to note now that FQHCs that participated in this study were not able to report the anatomical sites of screening. Next slide, please. By the end of the intervention, 8 health centers were routinely screening HIV negative or unknown status LGBT patients for HIV. The number of lesbian, gay, bisexual, and transgender patients screened for HIV increased from 806 in March of 2016 to 1,873 in March of 2017. But again, the percentage decreased from 33% in the beginning of the intervention to 31% at the end of the intervention. Next slide, please. We were surprised at the unexpectedly low HIV and STD screening of LGBT patients. For all of them, although the number of LGBT patients tested for HIV and STDs increased during the intervention, the percentages decreased. The top 5 issues health centers identified as to why this may be the case were that tests were not being ordered or done, tests were being done but not documented appropriately, the collected sexual orientation and gender identity information was not linked to structured variables that were used for monitoring and evaluation, such as ordered tests, ordered labs, or test results. Tests were not done because the patient was quote unquote not at risk, or tests were not done because the clinician focus had been on collecting sexual orientation and gender identity documentation, and they didn't have the bandwidth basically to also screen those that were identified as LGBT for HIV and STDs. Next slide, please. As previously mentioned, the greatest challenge was overall reporting. Of the participating 10 health centers, 1 did not report on any of these 5 measures because they had staffing issues, an inconsistent provider champion, and they had issues developing an electronic health record that routinely collected and reported sexual orientation and gender identity data. Consequently, they were only able to collect SOGI information anonymously and by paper. Next slide, please. Another health center only reported on sexual orientation and gender identity because they had merged with another larger health center and LGBT healthcare was not a priority. So they only did the minimum required to meet the Health Resources and Services Administration requirements, and they did not otherwise focus on their LGBT patients. Next slide, please. The pre-post measures were a detailed set of questions concerning policies and practices that were collected both pre and post intervention to assess the impact of the project not being measured by the monthly data. Of the 15 activities selected, 8 showed statistically significant changes between March of 2016 and March of 2017. Next slide, please. While many of these questions covered topics that were also being measured by the monthly data for quality assurance, which are shown in the red circles, there were specific questions concerning practices denoted by the orange stars, like LGBT signage clearly posted in public areas of the health center, and frequency of LGBT health-focused grand rounds and other sexual and gender minority educational opportunities. Next slide, please. But even for those that didn't reach statistical significance, there was still an increase in the number of sites reporting that particular activity between March of 2016 and March of 2017. Next slide, please. For example, by the end of the intervention, greater than 90% of participating health centers had policies in place protecting patients and staff from discrimination based on sexual orientation and gender expression, and also had mechanisms in place for reporting and addressing discrimination or disrespect. Next slide, please. One of the greatest successes of the intervention was the overwhelming interest in this project specifically and in LGBT health in general. More sites applied than we could enroll, and it is important to mention no funding or additional resources were provided to health centers participating in this intensive year-long intervention. This table shows the increase in spread of participating providers and sites by health center from March 2016 to March 2017. Next slide, please. 4 of the 10 participating health centers expanded this intervention to 100% of their providers, circled in red. And 5 of the 10 participating health centers expanded the intervention to 100% of their sites, circled in green. And you can see that there are 4 sites that by the end of this 1-year-long intensive intervention had both 100% of their providers and 100% of their sites participating. Next slide, please. So the conclusions that this particular article, this particular project came to were that this was a unique design. It incorporated practice improvement collaboratives and Project ECHO. It appears to be the first published report of a national quality improvement collaborative focused on culturally affirming care for LGBT people. It's also the first Project ECHO to focus on a population rather than a disease, disorder, or medical specialty. There were performance improvements. SOGI documentation increased significantly, and also targeted and HIV screening of LGBT patients improved. At least the numbers improved, even if the percentages didn't. And there were also some significant LGBT culturally affirming practices and policies put into place. Again, these accomplishments were impressive given the short time frame, the lack of funding for participating federally qualified health centers, and the typical challenges encountered by primary care sites in implementing new systems and guidelines, especially in modifying electronic health records. The biggest challenge, as mentioned, was FQHCs conducting and capturing risk-based sexual history. And this isn't surprising given the many documented barriers among clinicians in sexual history taking. Providers may find it easier to universally screen all people based on identity alone rather than provide targeted screening according to the specific sexual practices. Next slide, please. I'm now going to talk a little bit about using sexual orientation and gender identity data in electronic health records to assess for disparities in preventive health screening services. Next slide, please. As a reminder of something we already spoke about, lesbians are less likely to get preventive services for cancer, and LGBT patients in general, or LGBT populations, have the highest rates of tobacco use and abuse. Next slide, please. We assessed an approach for using sexual orientation and gender identity electronic health record data to identify potential preventive health screening disparities. We enrolled 5 federally qualified health centers from the previous study and retrospectively extracted 3 consecutive months of electronic health record patient data on sexual orientation and gender identity and routine screening for cervical cancer, tobacco use, and clinical depression. The screening data were stratified across sexual orientation and gender identity categories, and statistically significant differences in screening compliance across the SOGI categories within each FQHC were identified. Within each FQHC. Sorry. Next slide, please. In all FQHCs, cervical cancer screening percentages were lower among lesbian patients than among bisexual and heterosexual patients. In 3 FQHCs, cervical cancer screening percentages were lower for transgender men than for cisgender women. Within each FQHC, we observed statistically significant associations between sexual orientation and gender identity categories in at least one screening measure. The small number of transgender patients and limitations in electronic health record functionality created challenges in interpretation of SOGI data. Next slide, please. So the conclusions in this particular manuscript, in this particular part of the study, were that this was the first published report of using sexual orientation and gender identity data from electronic health records to detect potential disparities in healthcare services for LGBT patients. Findings were consistent with the research literature and suggest that using SOGI electronic health record data to detect preventive screening disparities has value. Electronic health record functionality should allow for cross-checking gender identity and sex assigned at birth to reduce errors in data interpretation. Additional functionality, like clinical decision support based on anatomical inventories rather than gender identity, is needed to more accurately identify services that transgender patients need. Next slide, please. I'm now going to talk about taking comprehensive sexual histories. The sexual history should be taken during a patient's initial visit, during routine preventive exams, and when you see any signs of sexually transmitted infections among the patients. These sexual histories help normalize the collection of sexual orientation and gender identity information. They help elicit specific behaviors, such as receptive oral intercourse, receptive anal intercourse, or insertive sex, to identify anatomical sites to be tested. They also identify risk factors, such as the number of partners, the types of partners, whether they're pseudo-anonymous or partners they may have met on apps. So they know their profile name, but they may not know their last name or their phone number or their address. Whether or not patients had sex while drunk or high. And you need to ask these questions in order to determine frequency of testing. Comprehensive sexual histories also identify gaps in preventive health care, rectal pap smears, cervical pap smears, immunizations, and it also guides patient education and risk reduction counseling messages. Next slide, please. Hopefully you're all familiar with the 5 Ps of sexual history taking. If not, it can be found on the CDC's website under STD treatment sexual history. There's a PDF on there that can be downloaded. But typically when you talk about the 5 Ps of sexual history taking, you're talking about partners, the first P, which includes the number of partners, whether or not there were any anonymous or pseudo-anonymous partners, whether or not they had ever been coerced into sex through one of their partners, and really need to talk about the concept of concurrency, that they're not only having sex with their partners, but they're also being exposed, possibly exposed to infections that from their partners, especially within certain time frames. The second P of the 5 Ps are practices. And this is where you can specifically focus on things like insertive versus receptive intercourse of the mouth and the butt. Transactional sex, that's a risk factor for HIV and STDs. Whether or not they use toys, if they use sex toys, do they share these sex toys? And if they share these sex toys, are they cleaning them appropriately before sharing? And then also drug and alcohol use. Are they having sex while they're high, or they're inhibited or unable to make proper decisions? The third P of the 5 Ps of sexual history taking is a past history of sexually transmitted infections. Here you want to find out what the infection was, where the anatomical site was, what their HIV status is, when they were last tested for HIV. There's a lot of people out there who had an HIV test a year ago and they still consider themselves HIV negative despite having multiple partners and high-risk interactions between that negative HIV test and the current time. And there's also, you also want to know about partner notification, whether or not last time they were diagnosed and treated with an STI, they let their partners know, whether or not their partners got treated. Could what you were seeing now, the symptomatology, what we're seeing now, be a reinfection because this didn't happen? Those types of things. The fourth P of the 5 Ps is protection. Ask whether or not they use condoms. If they do, what type of intercourse do they use condoms for? Some people only use condoms for anal intercourse, receptive anal intercourse. Some people use them for insertive and receptive anal intercourse. There are people out there that use condoms for oral sex, both insertive and receptive oral sex. If they're HIV positive or HIV negative, you also need to talk about serosorting, whether or not they choose their partners based on similar HIV status. And then finally, you can talk about vaccinations. There are several infections that can be transmitted sexually that have vaccines out there. And that's a great way of primarily preventing these folks from getting those infections. And then the final P, historically, of the 5 Ps of sexual history taking is pregnancy prevention. Birth control, family planning, again, you can talk about condoms here, those types of things. The next slide, please. So the 6th P of sexual history taking equals plus. And more information about this can be found at the National Coalition for Sexual Health's website under the providers icon. And specifically, this tool is called the Sexual Health Questions to Ask All Patients. And it includes the 5 Ps we just talked about, but it also includes the 6th P, which stands for plus. And some of the things that can be ferreted out during the 6th P or plus is pleasure. Is sex pleasurable? If not, why? You can talk about sexual desires and boundaries with your partner. If not, why? What's holding you back from a better sex life if they're not happy with their sex life as is? Another category you can explore during this is that there are some men, especially men who have sex with men, where pleasure is more important than remaining HIV or STD free. So if they are barebackers, if they don't use condoms or never will, then that's probably not something you should talk to them about when you're trying to educate them or counsel them about HIV and STD prevention. The second possible area you can explore for the 6P is problems. Are you having difficulties when having sex? Is there pain? Is there discomfort? Is there lack of arousal? Is there lack of orgasm? Or is your partner having difficulties when having sex? All of the same things. Are you concerned about your sex drive? Are you concerned about the sex drive of your partners? And if so, why? Then the final P that we just recommend, or the National Coalition of Sexual Health recommends exploring during the plus, is pride. But what they talk about is pride specifically focuses on the LGBT population. And you can ask questions like, what support, if any, do you have from your family and friends about your sexual orientation or your gender identity? And if they don't have support, is that a problem for them? Or have they created their own family that makes up for their blood family not being there or not being supportive? I think it's important for the LGBT patients to be asked if they're experiencing or have experienced any harassment or violence due to their sexual orientation or gender identity. You may want to also ask things about whether or not they feel shame or guilt about the sex they're having or their behaviors, trying to get at things like internalized homophobia that can sometimes drive behaviors that lead a patient to be at increased risk for sexually transmitted infections and HIV. Next slide, please. So I just want to review the top 10 health issues affecting lesbians, gay, men, bisexuals, and transgender people, and I'm going to review these for each of these 4 categories. These come from the Gay and Lesbian Medical Association's website, which can be found at www.glma.org, and you'll see an icon for each of these. I want to preface this discussion by saying that I'm not going to go through all 10 of these for each of these LGBT categories, and I'm also going to tell you right off that some of these are based on data that they got from other places, and some are based on, let's call it subject matter expert consensus. So just bear that in mind as we go through this. Next slide, please. So these are the top 10 health issues that affect lesbians. And I want to point out that lesbians are more likely to have risk factors for breast cancer, yet less likely to get screened. So they're more likely to be obese, they're more likely to not have had children, they're more likely to smoke, but yet they're less likely to be screened for breast cancer. Heart disease is the leading cause of death for women in general, and smoking and obesity are the greatest risk factors for heart disease among lesbians, because smoking and obesity is higher among lesbians than heterosexual females. Lesbians also have higher risk for certain types of gynecological cancers than straight women. Lesbians are more likely to be overweight or obese than heterosexual women, and lesbians use tobacco more often than heterosexual women do. And finally, healthcare providers don't ask lesbian women about intimate partner violence as often as they ask straight women the same question. Next slide, please. These are the top 10 health issues affecting gay men. Sexual orientation and certain behaviors should guide screening and immunization practices. Pre-exposure prophylaxis, treatment as prevention, or U equals U. Undetectable equals untransmissible. All of these are HIV prevention tactics that are very effective and are especially important among men who have sex with men. MSM are at increased risk for sexually transmitted infections with viruses that cause hepatitis. So talking about hepatitis A, hepatitis B, and hepatitis C antibody screening, talking about hepatitis A and B vaccination status, those types of things are important among men who have sex with men. Problems with body image are much more common among gay men, and gay men are much more likely to experience an eating disorder such as anorexia or bulimia. And even if gay men don't have an eating order, such as the ones just mentioned, they are also more likely to have body dysmorphic syndrome, which means that they look at their bodies and they could be very fit and very muscular, but they're never fit or muscular enough. And unfortunately, that drives compulsive behavior, like sometimes using and abusing steroids. Gay men also use substances at a higher risk than the general population, not just in larger cities. And that's substances like anabolic steroids, but also things like GHB, ecstasy, crystal meth, those types of things. And finally, HPV vaccination and anal pap smears are important among men who have sex with men, especially HIV positive men who have sex with men, and especially HIV positive men who have sex with men who have a history of genital warts. or genital warts of the anal or anal genital warts, or any anal abnormalities on previous pap smears. Next slide, please. These are the top 10 health issues among bisexuals. And it's important to note that many providers are less familiar with bisexuality and make assumptions about behavior, which lead to either asking inappropriate questions or not asking appropriate questions. Depression and anxiety affect all sexual and gender minorities at a higher rate than the general population. This includes chronic stress from discrimination, internalized homophobia, which we mentioned before, and suicide, unfortunately, and this is especially true among youth. Sexually transmitted infections occur in active bisexuals at a high rate, and actually sometimes female bisexuals are at higher risk for STDs than heterosexual females because the male partners they choose tend to be very high risk. Bisexuals may be at risk for death by these cancers, prostate, testicular, breast, colon cancer, because they're not screened for them as the general population is. And finally, studies show that all sexual and gender minorities use tobacco at much higher rates than heterosexuals. Next slide, please. So these are the top 10 health issues among transgender persons. The first that I'm going to review is that it's not easy finding a healthcare provider who knows how to treat transgender people. And if you've ever taken care of a transgender person, you've probably heard some pretty bad horror stories about previous experiences with clinicians. And unfortunately, even if a competent provider is located, there can be issues with insurance and coverage. Trust is important, and details about all medications and surgeries should be shared and documented. This includes over-the-counter medicines. If you deal with undocumented patients or patients from Latin American or South American countries, oftentimes they're using hormones that are imported or from their native countries, and they're not really sure what are in these medications or what they're actually taking. You need to manage expectations about gender reaffirming therapies and progress. Education about side effects is also important. You need to talk about transactional sex because it's not uncommon among transgender females who may or may not be insured or may not be insured for the eventual gender reaffirming procedures that they want, and they use commercial sex work as a way of saving up money in order to start looking more like the way they feel. And then finally are the pumping parties, which provide transgender females with instant gratification. And if you're not familiar with pumping parties, they are when they get together, a group of transgender females, and they inject themselves with silicone into the parts of their body where they want to see curves. So typically it's the butt and the hips, and sometimes it's the breast area. But the unfortunate problem with this is that there's not a lot of regulation of these pumping parties, and oftentimes the silicone grade that is being injected into these women is not of surgical quality. Next slide, please. So I'm going to end on these last couple slides by reviewing what you can do to transform care for LGBT people. The first thing that can be done is the collection and capture of sexual orientation, gender identity, and sex at birth, and gender of sex partners within your health record. And it's not only asking these questions, it's capturing it in a structured field appropriately in the electronic health record so it can subsequently be pooled and then monitored and evaluated. And that gets to the next point of using these data for assessing disparities and improving care, especially among the LGBT population. You can institute policies to protect patients and staff from discrimination based on sexual orientation and gender expression. You can also help institute practices that make your clinic more welcoming to LGBT people, such as LGBT signage clearly posted in public spaces. You can collect, capture, and use preferred names and preferred pronouns. And it's important to not only capture these things in the electronic health record, but it's important that they're in the electronic health record. It's very visible to every part of the flow through the clinic. So the front office staff have to see the preferred pronouns and the preferred names. The medical assistants that taking the vital signs need to see that. The providers need to see it. The counselors who may see them after you diagnose and treat something need to see that as well. And then finally, you can also provide educational opportunities concentrating on LGBT health. Lectures and grand rounds, cultural humility training of new employees. And it's important to have these not only on uptake when you're hiring new employees, but also for everybody ongoing. Next slide, please. And here's some other things, what else you can do to transform care for LGBT people. Considering using anatomical inventories rather than sexual orientation and gender identity to target cancer screenings. Why this is important, in case it wasn't clear when I previously talked about this, is in our study, we identified several individuals based on identity who were flagged as needing cervical screening, but based on their identity, which should not have had a cervix in place. In other words, there were several transgender females who did not get cervical screening, and we're not sure if those were females who did have a cervix and were identifying as transgender female, or if they were actually male to female transgender patients who were not born with a cervix and they were misidentified or misclassified. This was especially a problem in our study, as mentioned, because we weren't able to link sexual identity or gender identity, with gender at birth. Another thing you can do is consider screening LGBT patients for mental health and substance abuse issues. This is especially important if you have PrEP patients or HIV patients and they're pseudo-primary care, you're seeing them every 3, 6, even 12 months in some cases. It's important to screen these patients for mental health and substance abuse regularly. You can also capture, follow, and address weights and discuss body mass index and body image, especially among gay men. You can capture tobacco usage and readiness to quit, and also identify ways that you can help patients quit, whether it's being comfortable using and prescribing Chantix or having a counselor on board that can talk them through their stages of readiness to quit, those types of things. You can inquire about intimate partner violence, and again, identify resources if needed. This is a problem among LGBT patients in general, but it's especially a problem among lesbians because they don't tend to be asked that question as much as heterosexual females or even gay men. You can also provide immunizations for sexually transmitted infections like hepatitis A, hepatitis B, and HPV, or the human papillomavirus. Next slide, please. Next slide, please. Can you go back a slide, Jimmy? Sorry. So these are the resources. Everything that I presented today can be found in one of these 5 places. The National Sexually Transmitted Infection Surveillance data were the graphs that I showed, and that includes information on men who have sex with men. The Transforming Primary Care for LGBT People Toolkit. So this is basically a toolkit for federally qualified health centers or other community health centers to do exactly what we did during that year-long intervention. I would recommend you checking it out. It's very, very thick. There's a lot of information in there, and I think it could be very useful. I pulled the 5 Ps of sexual history taking from the CDC website, but they're actually prevalent on many different websites. They are pretty ubiquitous. But I pulled the 6 P of sexual history taking specifically, as mentioned, from the National Coalition for Sexual Health website, and that's the link for it. And then finally, the top 10 health issues among LGBT patients that we reviewed came from the Gay and Lesbian Medical Association organization. Next slide, please, Jimmy. Thank you. And my contact information is there. That's my email address. I apologize, I went through rather quickly because I was worried about time because of our technical difficulties, but I am done and willing to take any questions if there happen to be. Thank you.
I hope you'll all join me in a virtual round of applause for Dr. Furness. Thank you very much for a wonderful presentation. I do apologize for the technical difficulties. We do have some time to answer questions, so use that question box to ask any question you might have. And while those are coming in, we do have a couple of questions that were submitted earlier. So there was a question about the ECHO project and I guess membership. Can anyone or organization join the ECHO project? How can my organization create an ECHO project or something similar?
That's a very good question. And the ECHO project is predominantly run out of the Community Health Center Incorporated in Connecticut. It was one of our 10 sites that we chose, but the Weitzman Institute is associated with the Community Health Center in Connecticut, and they are the ones that head up, spearhead these ECHO sessions. Typically what happens is organizations organize them and allow health centers to participate. So ours was specifically organized by the funding came from the Centers for Disease Control and Prevention, but the Fenway Institute was involved, the National Association of Community Health Centers was involved, and the Weitzman Institute was involved. I can share with Jimmy, who can share with you guys, the contact name and information at the Community Health Center Incorporated in Connecticut, and that's who I would reach out to about which ECHO sessions are already going on right now and whether or not you can participate, or if you wanted to organize an ECHO session for community health centers, how you would go about doing that.
So then our next question is, as a Latina OBGYN, I wonder how you reach out in a culturally appropriate ways. Was there any additional time given to providers to address this in a respectful and dignified way? Any intentional touchback with patients?
So that's a good question, and I think that depended on health, that varied between health center. I will say that the engagement that went on sometimes before these patients were seen was very important, and several health centers, because of this initiative and because of them wanting to improve LGBT healthcare, they hired outreach coordinators that worked with local community-based organizations that dealt with these particular populations. Several of these health centers identified LGBT staff, whether they were clinicians or they were counselors or they were community health workers or whatnot, and then those people were given additional responsibilities or were tasked with helping to make the places more inclusive for LGBT, helping the providers become more comfortable engaging and talking about some of these sexual histories with different patients. So I think there are lots of, and I would refer you to the toolkit because there's a lot in there, but the things that I think were most successful from these 10 health centers during this intervention were hiring LGBT coordinators or LGBT staff to try and improve things within their health centers, their different sites, and among all of their providers for the LGBT population. And then probably more prevalent, most sites probably identified LGBT staff that were already there and then asked them if they would like to take on a greater role in trying to improve things. So hopefully that answers your question. I think another thing, I don't want to underemphasize the signage, rainbow flags, giving somebody who's waiting in your waiting room a very clear indication that this is a safe space for LGBT patients, because you're going to get much more honest questions. You're going to get a much more transparent sexual history if they're comfortable talking with you about those things. I'm also going to refer you to the Gay and Lesbian Medical Association website because they have a lot of tools for providers on doing exactly what you're asking about.
And this is a question in the same vein, but just to reiterate, just in case there's anything else you wanted to touch on, were there any specific initiatives used to encourage our patients to come into the clinic to be tested on a regular basis, i.e. annually?
That's a good question. I think that there were not, I'm not aware of any of the health centers doing initiatives. I know that some of the health centers sent people to health fairs and had conversations with the LGBT population about national guidance for STD testing, frequency, and those types of things. So I guess, yes, there were initiatives, and I think those initiatives specifically dealt with the community health centers reaching out to community-based organizations and other organizations in the community that deal with LGBT patients and providing education and letting them know that they were doing this initiative to try and improve the healthcare for LGBT patients, and so they wanted the word to get out there, but they also wanted to educate the population and let them know what the national guidance was and help them identify whether or not they needed to be screened for certain things, and if they did, how frequently they needed to be screened. But I think that what I saw as the biggest initiative, if you will, is that providers were learning to ask the appropriate questions. And once the appropriate questions were asked, then the testing, the screening, the counseling, the education, the vaccination all stemmed from the conversations that happened after the patients were made comfortable, they were being honest and transparent with their answers to the questions, and that led to additional questions and additional conversations.
So I would like to thank you again for presenting this valuable research and thank everyone for participating and sticking with us. The presentation slides and CME evaluation will be available on our website, and please remember to complete the evaluation to receive CME credit. I hope everyone has a wonderful week, and I hope you all take care of yourselves. Thank you so much, Dr. Furness.
Thank you, Jimmy. Thank you, everybody, for paying attention.
Have a great day.
Bye.